Hello, my name is Daniel Herron. I'm a radiologist in Sacramento, California. I'm grateful to be talking to you. And I'm going to talk to you about breast imaging procedures, how to optimize accuracy, safety, and pain control. Basically, there's no right way to do this, but this is how I do it and what I've learned. This talk came out of my own desire to make sure I'm doing things the way I should be doing. You know, we all learn from how we were taught, how we observe people, and just experience. And I decided to take every piece of my procedural toolkit and analyze it to see was I doing it correctly. Mark Twain said this. Other people have said it similarly, but it ain't what you don't know that gets you into trouble. It's what you know for sure that just ain't so. And to be honest with you, I have changed several things in my process after learning some new materials. So I'll just share with you what I learned. I don't have any financial disclosures. Um, I'm going to cover several things about infections, how bleeding affects biopsies. I'll spend some time how we can prevent pain, a little bit on cosmetic considerations, and then focus on ultrasound guided procedures, which is the predominant way I do biopsies and probably for most of you. And we'll touch briefly on stereotactic procedures. Won't spend much time, if at all, on MRI procedures. First off, I was using iodine swabs in my practice, and I said, well, is that the right thing to do? So I did some research. It turns out the World Health Organization and the CDC recommends we use chlorhexidine gluconate, and 4 to 5% solution is 30% better than a 2% solution. Unfortunately, I could only find a 2 to 3% solution. So if you can find 4 to 5% alcohol swabs, that would be better. But anyway, I've gotten rid of iodine in my practice, although I think some of my interventional colleagues still use iodine, but most of them have switched to chlorhexidine. Hematomas, they are common. This is a lady that had a two-site biopsy on the same day for fibroadenomas. One had a hematoma, one didn't have a hematoma. And I noticed, gee, I seem to get a lot of hematomas with stereotactic biopsies and MRI. And well, that's what most people get. It turns out when we do ultrasound biopsies with 12 and 14 gauge instruments, you should expect about 4% hematoma rate, but about a quarter of your stereotactic guided biopsies will have a hematoma and almost half of your MRI guided biopsies. So another good reason I prefer ultrasound. So then we looked at our anticoagulation. We were telling people to quit their Coumadin 4 days ahead, stop their Plavix, don't take any Motrin, aspirin. It was sort of a big deal. So I said, well, how important is this? You know, I'm a long ways out of medical school, so I had to refresh my mind on how these things work. Aspirin inhibits platelet function, as does Plavix. Non-steroidal anti-inflammatory agents inhibit platelets. And warfarin affects several clotting factors, depletes vitamin K. But a lot of these are used to prevent DVTs, pulmonary embolisms, atrial fibrillation. Basically figured out I don't need to stop these medications with biopsies, whether it's with 9 gauge stereotactic or ultrasound 12 gauge. If you stop them, you might cause what they were trying to prevent. There was a study showing 3 months after someone stopped Plavix, their risk of myocardial infarction went up, and the idea was maybe there was a rebound hypercoagulability state. So basically, we've stopped telling people to discontinue their medications. They will get more hematomas, but they're not clinically significant. In one study, when you didn't stop anticoagulation, 22% of people had hematomas versus 13%. Again, they will get hematomas, but our practice, we've never had anybody have to go to the hospital, have to have it drained, have any intervention. In this study, they had hematomas ranging from 1 to 7 centimeters in diameter, and none of those patients had any intervention. So basically, we don't really even ask about their anticoagulations because it just stresses us out to know about it, but we don't stop them. I do favor using epinephrine in my when I use lidocaine. Epinephrine stimulates alpha-adrenergic receptors, causes vasoconstrictions, which increases vascular resistance and can increase blood pressure. It also stimulates the heart, the beta adrenergic receptors, which can increase heart rate and contractility. Mostly we're using a 1 to 100,000 solution, and there's studies. A lot of these studies are in dental patients, but one mice study showed it did decrease incisional bleeding. You can have rare increases in blood pressure or heart rate, but again, these don't appear to be clinically significant. I think when a lot of patients say they're allergic to lidocaine, it was probably a side effect of the epinephrine. We'll talk a little bit about allergic reactions to lidocaine. So I'm a big fan of using epinephrine. I also thought, well, it might not be safe for the dermis. Traditionally, people were not using epinephrine of lidocaine for terminal arteries like noses, digits, ears, penis. I did find one case report of a little bit of skin necrosis, but the patient had had a mastectomy with nipple reconstruction and radiation. So maybe if you have that patient, don't use epinephrine. But basically, I use it in all my procedures. I don't use plain lidocaine as long as I can get lidocaine with epinephrine. Pain management. This is a big issue. Patients are obviously scared and worried about their biopsies, and I think we can do these not painlessly, but with very little pain. Just going back to lidocaine, this was developed in Sweden. I thought it was funny when I did research. When they originally did the research, they recruited medical students and they offered them either $1 or a pack of Lucky Strike or Camel cigarettes. I don't know how many chose which, but I basically looked into the doses I should be using. If you use plain 1% lidocaine, the maximum dose is 4.5 milligrams per kilogram. For a 70 kilogram person, that's about 30 milliliters of your solution. The nice thing is if you add epinephrine, you can use almost twice as much of that. So you can use up to 50 milliliters. It works very quickly, probably works quicker than 1 to 3 minutes. Plain lidocaine may last for 2 hours. If you add epinephrine, it lasts 2 to 4 hours. Another reason I like epinephrine, I can use more of it and it lasts longer and it decreases bleeding. You can use this calculation if you use other agents like mepivacaine, bupivacaine. But again, an example, 1% lidocaine with epinephrine, you put it in the equation. It'll calculate. If you have a very large person, you can calculate how much you could give them more, or if you have a very small patient, you could calculate that you may need to give them less. The location where you inject the lidocaine is very important. This became apparent to me during COVID when there was a lidocaine shortage, and I used to typically always use 20 cc's for every patient. I've now pretty much used 10 cc's. A couple patients I've gotten away with 5 cc's, but I can see directly where I'm injecting. I inject above the lesion, below the lesion, into the lesion, and also realized I don't need to numb up the whole lesion. If I have a 3 centimeter lesion, I can just numb up part of it where I'm going to put the needle. For stereotactic and MRI guided biopsies, you're a little bit blind on where you're putting the anesthetic. You're sort of going along the track. So I typically use more anesthetic, usually 20 to 30% per site. So that can become an issue. I don't know about the rest of your practices, but occasionally we're doing like 3 sites, maybe 2 on one and 1 on the other. So it can become an issue. Sometimes you need to reschedule these patients for 2 different days, depending on how many sites you're doing, if you really want to stay below the limits of your lidocaine. There are side effects of lidocaine. People can have numbness in their mouth, tongue paresthesias, dizziness, tinnitus, blurred vision. Occasionally, I've had people report these. There was a study that you can have severe reactions in peripheral nerve blocks, but again, it's rare, 1 in 2,000 cases. Seizures are rare, but they can happen. You could treat this with benzodiazepines, which lower the seizure threshold. You can get cardiac arrhythms, bradycardia, even asystole at a dose of 800 milligrams. Remember, the dose was like 500 milligrams with epinephrine for a 70-kilogram person. So there's not a huge swing between 500 and 800. You need to be careful. You can treat this with lipid emulsion therapy. This is a bit tongue in cheek because I'm pretty sure none of us have lipid emulsion therapy in our office. So probably the important thing is just not to have this happen. I do remember a case. I used to be an obstetrician, and late one night, needed to do an emergency C-section. The baby's heart rate had dropped. Anesthesia wasn't there. I ended up doing the case with local lidocaine. I'm pretty sure I probably used in retrospect about 1,000 milligrams. They just kept handing me syringes as I numbed up the skin, subcutaneous tissue, fascia, peritoneum, uterus. Um, Fortunately, anesthesia showed up after the baby came out and put her to sleep. The baby was fine. She was fine. So I think I was just lucky that she didn't have a severe side effect from the lidocaine. Talking about lidocaine allergies, we all have patients say, I'm allergic to that. True allergy to lidocaine is very rare if it exists. Most people are describing autonomic reactions. They get faint, phobias, panic attacks, maybe a side effect to the epinephrine. If we give too much or inject it intravascularly, they could get more side effects. You can do skin testing, intradermal tests for a true allergy. But probably if 100 people tell you they have a lidocaine allergy, maybe one of them truly has an allergy. I did have a patient last year, a man in his 50s. I biopsied his lymph node and everything went fine. And I get a call later from his wife that on the way home, he started having trouble breathing, developed a rash. She took him to an emergency room, and apparently he was treated for an anaphylactic reaction and spent 3 days in the intensive care unit. The only thing we gave him was lidocaine in our office. So presumably that was it. I guess he's had these reactions to many, many medications. He didn't know he had a lidocaine allergy. So maybe that was my one case. When people, I was just going to touch on that. I don't know if you know, if any of you watch soccer. It seems like these soccer players fall down on the field in agony, and the next thing you know, they spray this thing on their leg and they pop up. I don't have that magic spray. It may be this ethyl chloride. I used to watch a show called Doc Martin about a general practitioner, and he always sprayed something on their skin before he injected. I don't have this spray. I don't know if it would be sterile, but it also may be helpful. If someone tells me they're allergic to lidocaine, there are alternatives. You can use prilocaine, mepivacaine, bupivacaine. We usually just keep a bottle of mepivacaine in our office, and you can have cross-reactivity between lidocaine and mepivacaine. I think being allergic to both would be pretty rare. They're probably not allergic to the first one anyway, so I just use a different one and have never had a problem. Lidocaine's in the same class with these, the AMI class. There's another class called ester class. You could use procaine. Benzocaine doesn't cross-react apparently at all, but it's a topical anesthetic, so not a good option. What else can you do for pain control? Well, we distract patients with music. I guess it's legal if your tech has Spotify or Pandora on her phone and just shares it. So we ask the patient what they want to listen to. It helps to talk to them. I have a very kind technologist who says, pick a topic of distraction, and they'll talk about cats, dogs, their kids, vacation while I'm doing my thing. And I think that helps. It can help to have an assistant hold their hand. There was a story in The Guardian last month of someone describing a kindness at a hospital. I think she had an MRI guided biopsy, and basically someone just put their hand on her back during the procedure, which was very comforting. So I thought that was a nice thing. I try to inject perpendicular to the skin at 90 degrees, not come in at an angle. Basically, you're just traversing less dermis with your needle, which is helpful. People talk about injecting slowly, or some people will use these slow pulses as they're injecting. So sort of a combination of that is nice. If you have to pull the needle out and go back in, it's nice to go back in the part that's already numb. Sometimes if you're doing multiple injections and using the same needle, it can get dull pretty quickly. I use a 25 gauge needle for most of my cases. I know there are people that'll put on a 27 gauge needle just for the skin and then switch out to a 25 gauge needle. The 25 gauge needle seems to be a good all purpose needle. It can bend in dense tissue. And sometimes after I've numbed them up a little bit, I'll switch to a 20 gauge needle if I can't get through the thick breast tissue. I also have spinal needles on hand, a 20 and 22 gauge, which is very helpful and used frequently. I put bicarbonate in my lidocaine. I have a bottle of bicarbonate, and basically there have been studies showing that it's helpful. I mean, the patients, the painful part is the skin traversing the breast tissue, and then actually when you get into the mass, partly it's probably due to the acidity of lidocaine, which is about 1,000 times more acidic than the body pH, and the bicarbonate can sort of balance this out. So basically, I have a 10 cc syringe. I pull up a cc of bicarbonate, fill the rest of the syringe with lidocaine, sort of swish it around, and I'm good to go. There was a study showing it helps both with the superficial injection pain and the actual pain of getting the sample within the mass. It was interesting in terms of parenchymal pain. It sort of depended on whether they had fatty or scattered fibroglandular densities. So it appeared to be working better in people with fatty breasts. But none of these patients felt more pain with the bicarbonate. Many felt less pain. So basically, I use it for all of my procedures. You could also warm the anesthetic. There have been studies showing that the lidocaine at about 104 to 130 degrees Fahrenheit is helpful. It also may speed the action of the anesthetic. The problem is I've never been able to figure out a way to warm it and know what the temperature is so that it's not too warm or not too cold, and also keep it handy. So if you can figure out a way to do this, good for you, but I just wasn't able to do this in my practice. I thought I'd also share with you something I learned called the peak end rule. This is from the psychology literature. But basically, the idea is we tend to remember the peak feeling of an experience, whether it was good or bad, and we remember how it ended. So I used to think, well, I should just make this procedure as quick as possible, get the lidocaine in quick, move along, get them out of there. But actually, it would make more sense to take longer to inject the lidocaine, make sure they're very, very numb, give it some time to work. And then it also makes sense to end the procedure nicely. So no pain at the very end. So don't strip off any bandages quickly, for example. There were studies where they actually did sigmoidoscopy and colonoscopy, and at the end they just left it in for a minute while they were talking to the patient, so there was no pain at the end. You could also apply this to your life, like vacations. It might make more sense to have a 3-day vacation with lots of fun than a 2-week vacation where nothing much happens. Also, if you can do it, avoid an unpleasant trip home from the vacation. We probably all experienced this: missed flights, delayed flights. A terrible experience in the end sort of colors the whole vacation. So you can apply this to other parts of your life. In terms of cosmesis, I try not to put my instruments into the inner upper part of the breast. It's the part not covered by bikinis and bras. There are all these tissue lines. There's different names for them, Langer's lines, and it gets a bit complicated. It depends on the breast size. It depends on how the breasts hang when the patient is standing up. Essentially, I've actually gotten away from making incisions in many patients. I have these trocars that are very sharp introducers for my 12 and 14 gauge biopsy instruments. My vacuum instrument goes right through the skin easily. So I make less and less incisions, but sometimes you have to make a little nick. And I guess in general, if I'm below the breast, I sort of do it transversely. If I'm at the side of the breast, I do it sagittally up and down. It's not an exact science, but something to maybe think about. So ultrasound, just a little bit of time on that. I try to do everything with ultrasound. There's no radiation. The whole breast is accessible. I can see where my needle's going, my anesthetic's going. It's less expensive. It's generally quicker. People who have had all sorts of biopsies will tell you they will prefer the ultrasound biopsies. In terms of my ultrasound biopsies, it's important to have everything ready and not spend a lot of time with the patient there waiting. So I got everything ready in the order I'm going to use it. So first thing I'm going to use is my swab, then my needle. Again, I'm not using the scalpel very much, but I'm a big fan of using an introducer coaxial needle. For one point, it's sharp and I don't need to make an incision. But once the axial needle's in, I can just keep putting my instrument through the same hole. It also is important to have the ultrasound probe perpendicular to your needle so you can see the whole course of your needle, including if you're going to fire it, the distal extent of where it will be fired. When I use vacuum instruments, it's important to have the trough below the lesion. In this study, she recommended getting 4 to 5 samples with a 14 gauge needle. I'm mostly using a 12 gauge needle, but I will get 4 to 5 samples even with that needle. And then the vacuum just sort of depends on how big the lesion is, how many samples I will get. If you're going to use a spinal needle, I've had spinal needles bend within the tissue, and you can leave the stylet in until you're all the way in past the lesion, then take the stylet out. But we've all experienced some tissue that'll bend our 25 gauge needles, our spinal needles, but leaving the stylet in helps. It's important not to have the needle at too shallow an angle. It should be close to parallel to the chest wall. Sometimes it's hard to see the needle. Some of the new ultrasound machines have some software to help you see the needle. I do remember we sent a case into ACR for our Breast Imaging Center of Excellence, and we got dinged because they said our needle was at too sharp of an angle on the images. So just something to remind yourself about staying parallel to the chest wall. I also learned about how tissue sinks in formalin. Fatty tissue tends to float on top of the formalin. Typically, a piece of cancer is going to sink to the bottom of the formalin. So I use this when I'm doing how many samples I'm going to acquire. If I think I have a cancer and I look over and all my samples are floating on top of the formalin, I pretty much realize I don't have a good sample. Once I get a sample that sinks, I'm reassured. Or if my first sample sinks, I realize I don't need too many more samples after that. In general, a larger gauge is better in terms of limiting false negatives and missing the lesions. Most of us are using like a 9 gauge needle for MRI and stereo biopsies. The larger the needle, the less false negatives. A 14 gauge needle might have 4% false negatives. The larger needles will have less. Basically, you don't want to underestimate. If you have invasive disease, you don't want to think you have DCIS going into it. Or if you have DCIS or invasive disease, you don't want to think you have ADH. Ultrasound can underestimate it, but it's a very small percent if you're using a larger gauge needle. There are some advantages to using a vacuum system. I have a vacuum system that I use, not on every case. The nice thing is you can have a single insertion. I think it's very good for small lesions I might miss. A lot of my partners are calling back for biopsy 3 mm things, 4 mm things. So it would be certainly easy to miss this with a 14 gauge or even a 12 gauge needle. But my vacuum device, I think I'm pretty good about getting them. You can remove small masses completely, such as small little papillomas. You can even remove a fibroadenoma if you want to take the time. I don't generally try to do this. And in general, you will get more tissue removed. You can get up to like 100 milligrams of tissue versus 15 milligrams. So there's less risk of future upgrade or false negative sampling. It typically will be more expensive. And I do have more bleeding and hematomas when I use the vacuum But again, this is rarely or never clinically significant in terms of having to do a follow-up intervention. Um, False negatives can occur with biopsies. They're not frequent. You're going to see them more if you have a very deep lesion, or maybe it's just hard to see your needle, and very dense tissue. You may not get as many good samples. So this does happen. And it's important to correlate your pathology with your imaging findings. And we report this in our dictations. We just say, is it discordant or is it concordant? In big reviews of the studies, they say, maybe 10% of biopsies will go on to excision with malignancy rates of 17%. I think this may be high. I think as we're using larger gauge needles and vacuum, this happens less frequently. In terms of axillary lymph node biopsies, before I get into it, I just thought this was a funny picture. On my bike going to work, sometimes I pass a church. It's for some sort of a group of motorcyclists, but I make fun of California. There's a sign for everything. So in case you don't see this gate is closed, there's a sign to remind you of that. So lymph nodes, our surgeons are increasingly asking us to biopsy lymph nodes. They want to know ahead of time. Suspicious lymph nodes have a thickened cortex, loss of hilum, and such. Basically, cancer starts coming in at the cortex. So usually it's the cortex that's going to get abnormal first, the hypoechoic cortex, and lastly, the hilum. So when I'm sampling, I'm trying to get through the cortex and some of the tissue outside the cortex, so they can know if it's spread outside the cortex. Usually we use like a 3 mm cutoff for a thickened cortex if we have someone we think has cancer. We use Doppler to avoid vessels. I always pre-fire my needle. I don't want to fire it through the lymph node and risk hitting the axillary vein or artery. I have never had this happen, and I'm hoping to retire without this happening. Again, if you have a tumor replaced lymph node, it oftentimes will sink. But a lot of these lymph nodes, they'll be sort of floating midway in the formalin or at the top and still have an adequate sample. We actually oftentimes, if we think they have lymphoma, we put a couple samples in this RMPI solution, the pathologist want, and then a couple samples in the formalin. We also put clips in our lymph node. This is a ring clip in a lymph node. Our surgeons are increasingly asking us to localize these before surgery for removal. Biopsy in women with breast implants. This is another sign in California. I was staying on the third floor of a hotel, and I come out to the lobby. There was elevators on my right and stairs on my left, and in front of me was a fire exit, but it had a sign there telling me not to use this exit to get to the lobby. So I ended up taking the stairs. Implants. A lot of patients have implants. We're increasingly doing biopsies in these patients. Again, it's very important to watch the whole procedure with ultrasound. So needle going into the skin, scalpel going through the skin, everything through the breast, making sure I don't fire past the lesion into the implant, stay parallel to the implant. Sometimes I target the superficial aspect of the mass away from the implant. You can inject lidocaine below the lesion. I'm not sure how helpful this is. It washes out pretty quickly. This is just an example of a needle going through a lesion close to an implant. I'm also a big fan of converting stereotactic guided biopsies to ultrasound. A lot of times you can see calcifications or some sort of a mass on ultrasound. It's quicker for the patient, more comfortable, less bleeding. You can also, once you sample it, do a specimen radiograph and see if you can see little calcifications in your specimen just to make sure you got the right thing. You can also convert a lot of MRI biopsies to ultrasound. Certainly, if it's a mass over 5 millimeters, most of the time we'll try to find it with ultrasound. I'm also surprised if you have a fairly large area of non-mass enhancement on MRI. Oftentimes you will see something abnormal in ultrasound, some thickened ducts, dilated ducts, just won't quite look like the rest of the tissue. So try to convert as many MRI biopsies to ultrasound also. We do a lot of ultrasound localizations. we're using various clips. It seems like every week there's a new device out there. We're experimenting with several, but I've used 3 or 4 of these devices already, and now there's 2 more my surgeons want me to test out. Um, in terms of stereotactic and MRI guided biopsies, again, the tray is a little bit similar. I usually have 3 syringes of my lidocaine and bicarbonate set out because I'm going to use a greater amount of anesthetic. One thing I have learned is once I have the needle in place, just prior to the biopsy, I inject 10 milliliters of lidocaine through my port and just circumferentially 12, 1, 6, 9 o'clock injected. I used to just hook this up and then start the biopsy, and it would gradually go in while I'm doing the biopsy, but I realized it was all just getting sucked out at the same time. So I will inject this right at the very end and then look at the clock and wait a minute before I do my biopsy. The other thing I do is before pulling everything out, I will put the instrument on lavage, disconnect the lavage line, and try to suck out any blood or fluid before I release my clip, just to decrease migration. People also talk about after you do the stereotactic or MRI guided biopsy, your first post procedure mammogram, do it at a different orthogonal view. So if your approach was CC, your first view will be a lateral view, or if your approach was lateral, your first view will be a CC view. I mean, everybody's attempting to try to not get these clips to migrate, and sometimes it works and sometimes it doesn't. I'm also a big fan of using the stereotactic equipment. We have an upright unit, and you can do localizations with this also instead of using the grid. So this works pretty well. So if you have the capability of doing this, it's worth learning how to do this. Use your equipment for your localizations. The last thing I would just want to touch on is saying no to biopsies. This is a difficult topic, and there's lots of cases and I understand lots of issues around this, but I think it's important that we just don't do everything that we're asked to do. We have clinicians ask us to do things that maybe not be appropriate. We have patients that ask us things that may not be appropriate. So I think no can be used. We've certainly have had patients who have a normal lymph node and they say, well, can you just biopsy just to be sure? Or have clinicians refer someone who has clear gynecomastia, well, we just want to biopsy just to be sure. Or you have a mass that's been stable for 4 years and they say, well, we just want to be sure. So there's some ethical issues about this, but I do reserve the right to not proceed. There's cases with implant masses that's too close to the implant to be safe. I've had patients tell me, well, I'm going to get them out anyway, so if you bust it, I won't be mad. Well, they may or may not be mad, but I'm not going to try to do that. I also won't do a biopsy without putting a marker clip in. It sounds crazy maybe if they have a 6 centimeter cancer, but I've had cancers that got neoadjuvant therapy and disappeared, and then they want me to localize it. And it's hard you can't really see where it was. I've had patients who had biopsies of fibroadenomas in the past without a clip, and now they come back and it's not clear if it was the same fibroadenoma. Sometimes they get a second biopsy. So I put a clip in everything. I want to thank you for your attention. This is my little pup Oreo sitting on our back porch. Thank you very much.